So it's such a privilege to be here today, sort of a homecoming for me, and especially to talk about something that I do in my everyday practice. And I think something that I'd like to share with you as well. There are a lot of things evolving in the field of reproductive endocrinology, especially with PCOS, and the practice has been changing. And today, I hope I'll give you a glimpse of what we do back home and how, and not just back home actually, things are changing, and hopefully I'll get to show you that during the lecture. So these are my disclosures. This is a pharma-supported event, but the ideas and the papers that are presented here are, the ideas that are presented here are my own, and they're peer-reviewed journals, so you can access most of the data that I'll be showing here today. I'll also be talking about off-label uses of different medications used for fertility treatment. So let's start off with, this is the outline. And first off, let's start off with the pathology behind the syndrome. I know we usually talk about epidemiology and maybe the diagnosis, but today I'd like to highlight the pathology because I think there's something in the name that there's sort of misfit between the pathology and the name Polycystic Ovary Syndrome. So we know that PCOS is actually a very complex, chronic, and lifelong disease, and it actually starts even before the woman is born. It starts in utero, and when the fetus becomes subject to so many epigenetic and genetic factors, these include hyperandrogenism in the mother and endocrine disruptors, which we know are so prevalent in our environment today. And even these patients have a certain clinical picture too, and we can identify them even in utero. And we know them to be at risk for polycystic ovarian syndrome. And all of these changes actually carry over, even these are transgenerational. And so it's very important, I think, to recognize this when we're talking about this disease, because it's mainly a metabolic and endocrinologic disease more than anything. It's more than the ovary. It's more than the simple criterion that we have. The Rotterdam criteria, I'm sure you all know it, and it's something that um, I actually don't even need to go into detail with. But PCOS is more than that. These things I feel are too simple. Um, a lot of authors, a lot of investigators are looking at the role of insulin resistance as a key contributing factor in the pathogenesis of PCOS. And I think this is very important, and this is really key to what PCOS is about. It's really metabolic. Insulin resistance has many phases, and one of them in women is PCOS. And we've identified that, with insulin resistance, overstimulation of the ovaries, particularly the theca cells, can actually increase androgen production, hence hyperandrogenemia. It also acts as a protonadotropin for LH, and we know LH is the receptor for producing androgens in the theca cells. And also, it decreases in the liver production of sex hormone binding globulin. So all of these, because there is lower SHBG, you have more free androgen going around the bloodstream. And with increased production plus decreased SHBG, you have that really florid hyperandrogenism that we see with some patients with PCOS. But it's not as simple as just insulin. There is actually a society, the Androgen Excess PCOS Society, that really believes that it's hyperandrogenism that's the main problem. It's very intuitive because more than 80% of women who are hyperandrogenic actually have the disease as well. And it could be the basic pathology, but again, I'm showing this study here because it shows us that with it shows hyperandrogenic patients versus patients who don't have hyperandrogenism but are diagnosed with PCOS. And we see that the clinical picture, at least for the biochemical and aspect of it and the reproductive aspect, is very different. For those who are non-hyperandrogenic, we don't have the florid risks for metabolic syndrome and insulin resistance. So the picture is very, very different if a woman doesn't have hyperandrogenism. So there seems to be a partnership between the two. And later on, maybe as we discuss or as I go through the lecture, we'll hopefully try to elucidate or try to give clarity to maybe what the major factors are. Right now, it's chicken or the egg. We don't know yet. Um, it's an interesting discussion, but maybe we don't have enough time for the whole thing. But I'm sure there are a lot of investigators out there looking into this. So now let's go to diagnosis. I think there are a lot of learners here today, and this is very basic. This I know is a busy slide, but it really outlines how complex even the diagnosis is. The Rotterdam criteria is actually a very simplified way of diagnosing PCOS, hence it's why it's the most popular. But there are other ways to determine if a patient does have it. The Androgen Excess Society actually requires hyperandrogenism. And that's different for the most common one that we use, which is the Rotterdam criteria. And here we see the different phenotypes. There are basically various permutations of the presentations because we know that the Rotterdam criteria requires that there's either 2 out of 3, hyperandrogenism, ovulation problems, menstrual problems, or a PCO appearing ovary for us to diagnose these patients. But there is a phenotype where there is no hyperandrogenism, and these patients typically look very different. Their clinical picture is very different from the hyperandrogenic types. And so technically, there seems to be like 2 forms of PCOS, the hyperandrogenic and the non-hyperandrogenic, because their clinical picture is really so different. Now, the Rotterdam criteria, as I mentioned earlier, requires 2 out of 3. The diagnosis of oligo or anovulation depends likewise on the stage of the woman in her reproductive career, how remote she is from menarche. So early on, 1 to 3 years from menarche, the diagnosis of oligo-ovulation is actually a little more relaxed. It's more than 45 days. But for those who are in the thick of their reproductive career, 3 years to about the perimenopausal stage, it's about 21 to 35 days, which is what we know as normal. Amenorrhea is defined as not having periods for at least 90 days, 1 year post-menarche. So it's important that we give our adolescents that 1 year before we label them with PCOS because we know that the HPO axis really is very immature within the first year. So there's no labeling at that time. Also, the polycystic ovarian morphology. I really didn't go into detail here because I feel like it's not really the problem. I often say that the ovaries are really more of an innocent bystander of the whole metabolic process. So there is a set criteria, and I've written it here. But it's important to note that you need the proper bandwidth to diagnose it. So it differs depending on the type of ultrasound you're using. Now again, in PCO, in adolescents, the diagnosis is different. We don't require ultrasound in adolescents. In fact, ultrasound isn't very useful until after 8 years post-menarche. Now, how about hyperandrogenism? How do we define or diagnose hyperandrogenism? Well, we have the biochemical parameters and the clinical parameters. The biochemical parameters are fairly well described. The most accurate measure is of course, your calculated free testosterone. In my side of the world, it's not that accessible because it has a very stringent requirement for the assay. And so it's quite expensive. And uh, in a self-pay environment, we rarely get to use it really. Instead, we've relied pretty heavily on the clinical aspect of it. And so far, so good. The clinical aspect seems to work. For one of the most accurate um, is really hirsutism. And we use the modified Ferryman-Galway score to determine this. Locally, for Filipinos, we've determined that a score of more than 7 is considered abnormal. I know it's higher in other parts of the world, 8. Um, in East Asia, it's actually as low as more than 2 because of the genetic differences, the phenotypic differences. So it's important that you have that distinction. Now, how else can we diagnose hyperandrogenism? Well, we can also look at female pattern hair loss. It's also a reliable marker. For female pattern hair loss, it's more of um, the anterior hairline sparing type. So it's here. For male pattern hair loss, we have loss of, I'm not looking at anyone, okay? So we have loss of the anterior part of the hairline. So here in female pattern hair loss, it's preserved. And we have the Ludwig pattern or the Woodson pattern for this. How about AMH? This is quite popular. Can I see a show of hands for those who use AMH as a no one, no one. Okay, that's okay. That's okay because it's actually not standardized yet. There are proponents saying that AMH could be very useful, especially in the future when we've learned, when we actually have the standardization of it. So it's something, it's more of a wait and see. But I think there is emerging evidence that AMH can actually be very useful for determining the diagnosis. Now, I mentioned the interplay between hyperandrogenism and hyperinsulinemia, and it's really very complex. And that interplay actually results in the sequelae that are very morbid for PCOS. And that's why I feel part of the basic workup should be sort of screening for the risk factors of the disease, particularly insulin resistance and cardiovascular disease, because these are the number one killers of women eventually. So we really have to take care of our patients early on so they don't get these type of sequelae. Now, obstructive sleep apnea, we know, is part of cardiovascular disease risk, right? And we know that patients with PCOS actually have increased uh, risk for this. Endometrial cancer as well. I'm sure you've seen this in your practice. Another important thing is mental health screening. Mental health issues are very common in patients with PCOS, and this is apart from um, other issues involving body image, etc. Even without those, the patients still have an increased risk. So for insulin resistance, there are many ways to diagnose insulin resistance. I know the HOMA IR is used here a lot. We've had conversations recently with endocrinologists here, and they really rely on the HOMA IR. But uh, I put in all the normal values. And it's funny because they vary so differently. So in other words, it's not standardized. So it's very hard to pin down what's normal and not. I know here some of the endocrinologists use the less than 1.26 value, which is which is half that of the other areas. Now the clamping techniques are actually the gold standard, but they're mainly for research purposes. I don't know, I don't know if anyone really uses these for diagnosis of our patients, particularly because we have good alternatives anyway. Um, in my own practice, I use the 75 gram OGTT a lot because it's more practical and practical meaning cheaper and easier for the patients to access. I know it's difficult for them in a way, but they rather endure that than have to pay more. So yeah, fasting insulin has its value. So if you were to ask me, what the best combination or what the best tests are, it would be 75 gram OGTT and fasting insulin. Because fasting insulin does have a correlation with other metabolic parameters. So this is a summary of the things that we can ask, we can do for our patients on the first visit alone. Of course, cardiovascular risk assessment is very important. And with that is obstructive sleep apnea. There is a screening questionnaire available. It's very available online, and you can use these for your patients. It's pretty simple. Um, but maybe you should ask their husbands, not the patients themselves. Because every time I ask a patient if she snores, she never knows. It's the husband who says that she does. Endometrial cancer screening is also important if the patient does have symptoms. So we do a transvaginal and an endometrial biopsy for these patients. Now, mental health screening, thinking of, depression and anxiety, which is really much higher in these patients. Psychosexual dysfunction and eating disorders are pretty front and center for these patients as well. We know that a lot of our PCOS women are on the heavy side, and so it's very important to pick up on those eating disorders. Now let's go to therapeutic strategies for infertility. I won't go, there are so many therapeutic strategies for PCOS, but I'll be focusing mainly on infertility. Now, the European Society, the ESHRE guidelines actually recognize that lifestyle is very important. It's key in management of PCOS. And I totally agree with that because lifestyle alone actually can do wonders for these patients. And it's recognized worldwide. If you check most of the guidelines, lifestyle intervention is first tier in management. Now, pharmacological management depends on what the complaint of the patient is. And for our purposes today, it's infertility. So for infertility, the patients usually undergo ovulation induction, or as second line or third line, they undergo assisted reproductive techniques. But right now, there has been a shift. I know Canada no longer has clomiphene citrate in the market, and that's because really we've been finding that letrozole is much better. We've known this for decades, but it was only in 2018 that it was recognized that it is the better option. And it's a funny parallel with so many other available treatments that we have. It takes so long for people to catch on, just like for letrozole. Now, before we do all of these ovulation induction, intrauterine insemination or ART, of course, we have to check for tubal patency and semen analysis. Now, the medications that are used for our patients are actually off-label, so you may get questions from your patients. Our patients are very knowledgeable, and you will have that one or two patients who will ask you that, this isn't indicated for infertility. Why are you giving it to me? But it's best to reassure them that the data is robust. And in fact, it's endorsed by many infertility societies worldwide. Now, one thing specifically for infertility patients is that you have, for PCOS patients, is that you have to counsel them on the risks of OHSS and multiple gestation, because this particular population, as we know, is more at risk for this. Second line and third line treatments are there. And typically, if a patient fails the first line treatments, then it's time to refer to your friendly neighborhood REI or for the second line and third line treatments. Now, again, ESHRE really drives the point that lifestyle, mainly diet, exercise, glycemic control, is very important in preventing complications. So again, I said I agree with that so much because, PCOS is a product of our lifestyle. And maybe there is a group, many authors actually believe that PCOS may not have been a disease in the past. In fact, it's just an adaptive response to the environment back then. During the ancestral environment, there was starvation, fear, desperation. And so these adaptive responses that are akin to the clinical picture of PCOS actually could be physiological at the time. It was an advantage, particularly for insulin resistance, because we know that there's food scarcity, but we have to have our blood glucose levels fairly high, fairly relatively stable for us to function properly. And so in times of food scarcity, the thrifty gene kicks in. So, this is important too for enhanced energy storage. The hyperandrogenism could actually also be an advantage because it gives these women greater strength, even more aggression. And during that time, it was very important to have those traits. Now, lower conception rates were also uh, seen during that time, and this was an evolutionary advantage as well because it gave these women a longer conception, longer reproductive career, but wider space between the pregnancies. And so obviously this is beneficial to them. I can imagine being, a mother and having so many children while running away from, say, a saber-toothed tiger or a mammoth. It really is an advantage to have that well-spaced uh, pregnancy. So unfortunately, our environment now has created this maladaptive response. And this is basically the picture of what it is. We've somewhat devolved into this picture, and our lifestyle our lifestyle choices have given us that. Actually, our lifestyle choices seem to be killing us. So again, lifestyle is key. And but does lifestyle really help? Does it have actually clinical benefit? Well, this paper says that it does. This paper looked at lifestyle interventions versus no intervention alone. And they looked at the reproductive endocrine profile. The metabolic profile is obvious. We know that any lifestyle intervention can really help. It can help with males, females, everybody. But how about the reproductive endocrine profile? That one is not as intuitive. But what we see here is that there are significant benefits to lifestyle. And this includes even just exercise alone, no diets. So I think that's great, right? I haven't seen the paper that said just diet alone, but I guess with weight loss, that could help as well. So we see significant improvements noted in the reproductive profile, particularly sugar control, androgens, and even clinically as an improved score in the Ferriman Galley. So it works. But it's easy to throw around the phrase lifestyle. What exactly does it mean? Well, there's so many papers around, and the one that I often see is that there's not one diet. We know that there is a preponderance of various diets around the keto, intermittent fasting, but the commonality of them all is really a hypocaloric diet. So what we see actually in literature, most of the papers that I see look at 1,500 kilocalories a day or a 500 kilocalorie deficit. So it's difficult to translate it as a patient, but I know your system is quite good in that you have your partnerships with nutritionists and all that. So you can refer out if you're not comfortable giving the advice yourself. Exercise is defined as at least 150 minutes per week of moderate intensity exercise. So that's brisk walking, things that get your heart rate up. That one is a little bit easier for us gynecologists to advise to our patients. Now about the role of anti-androgens. What exactly is the role of these pharmacologic agents in infertility? There's almost no role because a lot of these anti-androgens, as you can see, are teratogenic. So typically, if a patient presents with infertility, the hyperandrogenism really takes a step back in terms of priority for treatment. But luckily, even lifestyle can improve hyperandrogenism. So lifestyle alone, as we saw earlier, right? It looked at lifestyle on the the biochemical profile. And this time it looked at lifestyle versus an already established treatment, which is metformin. So it's a uh, pharmacologic agent that was given to these patients. And what they saw was that although the total testosterone favored metformin, the metformin arm, there was a significant increase in SHBG in the lifestyle arm. So much so that in the free androgen index seemed to be better. The profile seemed to be better for patients on the lifestyle management. So even compared to an established treatment, lifestyle seems to work. Now, how about insulin sensitizers? Do they have a role? Definitely. And the most common is metformin. And show of hands again, does you guys give metformin to? So yeah, it's because it's a very established treatment. The data is robust. It's backed up by existing national and international guidelines. But from experience, a lot of our patients do have that pesky gastrointestinal side effect, and it actually affects compliance. I've had many patients, I would say maybe 10% of my patients can't tolerate the gastrointestinal side effects, and so I have to look for alternatives. Um, thiazolidine particularly pioglitazone, can be helpful too, and they can be given in women intending to get pregnant. Personally, I don't have a lot of experience with this, and that's because I start mostly with the inositols. Glucagon-like peptide 1, this is very popular now. Your GLP-1 receptor agonist. I'm sure everybody has heard of this and probably is using it. No, but the GLP-1 RAs are not given for our patients who are intending fertility, mainly because they're quite new, we don't have the data saying that it's safe. In fact, we might have to be in contraception while taking them. Now, the inositols they're not really a pharmaceutical agent. They are a nutraceutical, and they have been found to work well in terms of glycemic control. They essentially act as second messengers for insulin. So they are insulinomimetics, and they have a very favorable side effect profile. Um, the evidence it's rather a little bit smaller in scale than metformin, but it's getting there. And for now, let's go to infertility and the use of these medications for our infertile patients. Now, just a quick comment on letrozole. Uh, Letrozole has been, I talked about this earlier, it's already considered first line in treatment for ovulation induction. And if we look at the theoretical basis for this, we know that it really should work, and it has translated in clinical practice too, because we have an abundance of papers showing that in women with PCOS taking letrozole, there are significantly more ovulations and more live births in those taking letrozole versus those who are taking clomiphene citrate. And we've had this data for a long time. But the latest ASHRAE, but it was only in 2018 that they changed the recommendations to having letrozole as first line. And so we know that because if you notice in the mechanism of action, letrozole works peripherally. And so it sort of preserves the negative feedback response of estrogen on the brain. So you don't have that consistent gonadotropin production, unlike with clomiphene citrate, where the brain becomes blind because it acts centrally. So it really promotes a polyfollicular development. So that's the benefit of letrozole. It promotes monofollicular development and it sensitizes the follicles to respond to FSH. Because we know that it inhibits the aromatase enzyme, you do have a little bit of buildup of androgens, and this helps in terms of sensitizing the follicles for FSH. And of course, it potentiates that response. Now, another important thing is that it has no anti-estrogenic effect on the endometrium. And for us, REIs, it's very useful because we do have those patients who really have very thin endometrium, endometrial when we do give clomiphene. So we don't have the same problem with letrozole. Okay. Now let's go to the future directions. Now this is the tail end of the lecture, and I'll be talking mostly about something maybe in between lifestyle and pharma, and these are supplements, and particularly inositol. Now, ESHRE is a little bit silent in terms of their recommendations for the inositols, but they do say that there is some emerging data suggesting that it helps, especially in ovulation. But you know, this is at least 5 years old, and since then there have been a lot of data coming in, and I'll show you some of them as we go along. Now, for the inositols, what are they? They're essentially a ubiquitous molecule found everywhere in the body. We actually produce them in large amounts in our own bodies. So it's a natural molecule. It's a component actually in the cell membrane. And it's also found in nature, in the food that we take. It was previously known as vitamin B8, but because we can produce it on our own, um, we can't call it a vitamin anymore. So the most common inositols in nature are myo-inositol and D-chiroinositol. And myo-inositol is by far the most common. It acts as a second messenger to several important endocrine signals, including, of course, insulin. We mentioned that. Insulin, FSH, and TSH. D-chiroinositol, on the other hand, is produced from myo-inositol. And what it does is that with insulin signaling, so it's an insulin-sensitive reaction, it helps convert glucose to glycogen in the liver and skeletal muscle. So the end effect is decreasing the amount of glucose that we have in the bloodstream. So again, this is a simplified view of the effects of both myo-inositol and D-chiroinositol. Here we see that myo-inositol promotes glucose uptake while glucose storage, DCI promotes glucose storage. And this is via the production of myo-inositol to D-chiroinositol is via a unidirectional epimerase reaction, which is sensitive to insulin. So in times of hyperinsulinemia, or insulin insensitivity, such as what we see in patients with PCOS, there is a dampening of that response. So there lies maybe the key to the treatment of PCOS in terms of, to understanding the interplay of hyperandrogenism and hyperinsulinemia. Now we have something that links them together. And this can be seen in the clinical picture of the patients too. So this graph actually shows the levels of myo-inositol and D-chiroinositol in healthy women versus those with PCOS. And what we see here is that, at least for the somatic cells, when a woman has compensatory hyperinsulinemia, she becomes insensitive to insulin, correct? And so, because D-chiroinositol comes from myo-inositol, through that reaction that is insulin sensitive, there is a dearth of TCI in the somatic cells because you can't produce them because the epimerase enzyme is dampened. So that one is, we understand that makes sense. But how come this doesn't happen in the ovaries? So this graph here shows that the there actually is increased D-chiroinositol in the ovaries in women with hyperinsulinemia. And this can be explained by something that scientists call the ovarian paradox. For DCI and MCI, there seems to be a two inositol theory too. For the granulosa cell, the myoinositol works on the granulosa cell to produce estrogen by potentiating the effect of FSH. Now, D-chiroinositol acts on the theca cell by producing androgens. So it's a very different interplay, right? Likewise, D-chiroinositol is an aromatase inhibitor too. So the end effect, if you have continuous stimulation of the enzyme, you have much more D-chiroinositol producing androgens and blocking formation of estrogen. So there really is that hyperandrogenic milieu that we see in our patients with PCOS. And at the same time, the hyperandrogenism will alter the FSH receptors and make it less responsive to the granulosa cell receptors, making it less responsive to FSH. So you have a relative decrease in estrogen and an increase in your androgens. So again, this is the picture that this is how it looks like. So in the peripheral tissues, which are insulin sensitive, you don't have that problem because the epimerase enzyme is insensitive. But in the ovarian tissue, which retains its insulin sensitivity, the epimerase enzyme keeps on working and keeps on producing D-chiroinositol, which eventually will produce more and more androgens. And eventually, the end effect is no follicular growth. You have arrest of follicular growth, and that is apparent in the ultrasound of our patients. We see smaller, smaller follicles, many of them, those that have arrested during their growth, and that's the PCO morphology. Now, how about myoinositol in the ovaries? How does it work? These are the next papers that I'll be showing are on IVF. And I chose them because IVF is nice in that way because it shows us all the surrogate markers of successful pregnancy, not necessarily a live birth per se, but it shows us like every step of the way if there are improvements based on what you're giving the patient. So this paper actually, it was just an investigative paper that wanted to see the relationship of myoinositol on the production of estrogen. And a linear relationship means that there is a relationship and it's a direct relationship. So more myoinositol produces more estrogen. And that's something that we aim for in our cycles. And here, this translated clinically as well because the embryos seem to have better quality as there was an increase in myoinositol in the follicular fluid. So it seems to also help in terms of fertilization and tiding over the embryos to a real pregnancy, a live birth. Again, this looks at myoinositol and IVF again. And what it looked at was the surrogate markers again for success, namely decrease in usage of gonadotropins, the number of days of stimulation, and naturally the hyperstimulation risk. So what they saw here was that myoinositol really improves the ICSI outcomes because there were less days of treatment. There was less use of gonadotropins, hence less risk for ovarian hyperstimulation syndrome. Now, how did this translate to the clinical picture? Well, in terms of the number of follicles, it wasn't very apparent. In fact, there were more follicles in the non-myoinositol group. But the end effect in terms of pregnancy rates and live birth rates were exactly the same. In fact, there seemed to be even a trend. Sorry, this is a little small. There was a trend towards improvement for live birth rate, for clinical pregnancy with heartbeat. So myo-inositol seemed to help with that too. Now, an important thing that we have to look at too when we're giving anything to our patients, and particularly in patients who are undergoing fertility treatments, is whether they're safe and whether we can give them, they have a benefit for our patients when they do get pregnant. And there are studies showing that myo-inositol helps in decreasing the risk of gestational diabetes in pregnant women. And this is very important in PCOS, where these women are actually already at risk for gestational diabetes. And gestational diabetes is something very important because, again, it's not uncommon. In my side of the world, 1 out of 6 women actually have gestational diabetes, and I see that translates in my clinic as well. Now, this study looked at myo-inositol given to women at risk for GDM. So these are women who've had who have family history of type 2 diabetes, who are obese, or probably some women have PCOS too. And what they did find was that myo-inositol actually decreased the risk or decreased the diagnosis of gestational diabetes in these patients, and very significantly so. And in terms of the secondary outcomes, namely insulin therapy, polyhydramnios, and neonatal hypoglycemia, well, in the fetus, giving myo-inositol seemed to decrease the rates of neonatal hypoglycemia. Now, this is the same, more or less the same thing. They looked at patients who are at risk for GDM by virtue of having a parent with type 2 diabetes. And what they saw was that the gestational diabetes prevalence was much, much less in women who were given myo-inositol during pregnancy. Now, this is a summary of what we talked about earlier. This is one of my last slides. We talked about the pathology behind the syndrome and how perhaps it isn't the ovary and how insulin, hyperandrogenism, and all of that have this partnership in having all those florid clinical presentation of PCOS. And the diagnosis, therefore, is not that simple. I know the Rotterdam criteria is simple, but we have to look beyond that and look at the other risk factors too. And this translates to the therapeutic strategies that we give our patients with infertility. So lifestyle is key. Maybe it's the most important thing in patients with PCOS, because lifestyle alone can change the direction of her health and her baby's health. Future directions, there are new treatments available. They're very promising. I know that I showed you a nutraceutical. It's a supplement. It's something that it's very safe and something that we actually have in our own bodies. But what's surprising to see is that the clinical effect is almost equivalent to that of existing and established pharmaceutical products. And again, we go back to the time when PCOS may not have been a disease. Hopefully we can go back to that. Maybe not through having the ancestral environment. I mean, that's something. With this environment, hopefully we can replicate our response to the environment. And again, these are spaces to watch in the future. It's quite, I think, an exciting time for PCOS because we are at the brink of changing things. Maybe an intrepid mind or a creative mind here can change the name, because I think we all agree that the name isn't very nice. A lot of us don't like the name. So maybe it can come from this group. We don't know. So, but I pose that question out to you. And again, we are looking forward to more evidence on the inositols and maybe change in the guidelines.